I'm Associate Professor Andrew Weickhardt, Medical Oncologist here in Melbourne, Australia at the ANZUP session, and we're here with Associate Professor David Quinn talking about Pembrolizumab in bladder cancer. You presented some interesting data at the meeting. Can you tell me about the key results from the Keynote study?
Sure. So I presented an update on Keynote 045, which is a study that compares an immunotherapy that targets PD-1, Pembrolizumab, to chemotherapy with taxanes or vinflunine in the second line after platinum therapy. And this is an area where we've not had a standard of care in the past, although many drugs have been used. And so the study was designed to compare Pembrolizumab, which had shown activity in this setting, to what was a relative choice of standard of care with 3 different chemotherapy drugs.
And what do you think the key take-home messages for the practicing oncologists are from this study?
Well, I think the high points of the study are that Pembrolizumab produces a higher response, better overall survival and less side effects than chemotherapy. So it's not quite a slam dunk, as we say in the United States, in that the PFS is no different, but this is something we see with immunotherapy drugs. They tend not to produce a great PFS. They produce improvement in terms of survival and overall survival, in terms of response and overall survival.
So that's something I've noted in my practice, is certainly many patients progress very soon after starting them on immunotherapy. So what are the clinical parameters that might predict response or progression, early progression on these, and that came from the study? And I'm not talking about the biomarkers that we might test on tumour tissue, but were there any sort of predictive factors identified in this study?
Really not. There wasn't a great predictive factor either way. Now, we were testing the biomarkers, but that didn't work out. It wasn't predictive of giving Pembrolizumab or chemotherapy in one sense or another, which is a bit frustrating. Who's going to progress early? I think we don't know, and it's something that we're really working on. There's also the issue of when patients have progression, do you leave them on therapy? Waiting for response after progression can be a very difficult area, and I think we've been a little bit tempered by some results that we've seen in this and other studies. Most particularly when we start out and look at the survival in the 2 curves, there's a slight advantage to chemotherapy in the first 2 or 3 months. And from that perspective, there's an excess death risk in that for the patients that got the immunotherapy until it starts to work. So it seems to take a while. And it'd be nice to know who those people were that died early, but at this point we don't know. And it was a small number of people, but these are things that we have to continue to look at. It was also a pattern that we saw in a more recently presented study that has not been published, comparing atezolizumab immunotherapy to chemotherapy, where there was a slight excess death risk for the people that got the immunotherapy in the first couple of months in that study.
That was interesting. I suppose you're touching on the Inveted 211 data.
Yes.
To recap, there's been several phase 1, phase 2 trials of single-arm trials of PD-1, PD-L1 inhibitors. They all had very similar response rates, and the FDA approved in an accelerated fashion their use in the US. Many of us were expecting, given that the Pembrolizumab study was positive, that given the response rates were similar in the early trials, the atezolizumab data would be merely confirmatory of what we knew. What do you think about that study and how it changes our thinking about these drugs?
Well, I think that the data from Keynote 45, where we have our first level 1 evidence for immunotherapy in this setting, I think are important and are going to lead to approval of Pembrolizumab for this indication in many places outside of the US, including Australia and New Zealand and other places. So, and I think we thought that Inveted 211 would confirm the activity of atezolizumab, which we've been using off study in the United States for more than a year, where we see durable responses, good tolerability with the drug, and we have a comfort with it. So the Inveted 211 result, which was initially reported via press release as being negative, for its primary outcome came as a bit of a surprise. And the primary measure here was in patients that were PD-L1 high. They had a lot of the PD-L1 protein in their tumour tissue. And that was a comparison between the Tezo and the chemo, where there was not a significant difference in overall survival. The trial was designed so that that was the primary group on which approval might have been given. And then if that was positive, they got to move to the less positive patients and then the overall cohort. As it happens, the data has been presented by Tom Poles in Europe in the last few weeks, and we've got to look at the other data a little bit more. And the intention to treat study that was the third parameter down, which is what we'd normally use as our first parameter, was actually positive by the criteria we'd normally use, with a p-value of, I think, 0.03. So it may be that across the whole board there, the immunotherapy is still superior and with that drug, whereas the biomarker does not tell us what we think it's telling us. And so it's going to be interesting now to see. I think there'll be a movement of prescription of Pembrolizumab into the market, maybe some of the others, and then we'll have to look at subsequent studies for atezolizumab, which I think has activity, but just how much relative to the other 4 agents, no one can really tell you.
Yeah, right. I looked at your data that you presented here on quality of life in the Keynote 045 study, and it was pretty striking that the quality of life seemed to be significantly better in patients treated on the Pembrolizumab arm. There's still side effects, of course. Thinking about the atezolizumab INVIGOR 211 study, it's been widely described as being negative so far, but looking at the separation of the curves after the median is reached for overall survival, it still does seem to favour, obviously, the immunotherapy arm. And I wonder if we compared the quality of life in those two groups as well, whether or not patients would prefer, even if not statistically significant, the immunotherapy over the chemotherapy, cost aside.
I think the data that we've seen so far from INVIGOR 211 suggests that the quality of life is better with the immunotherapy than the chemo. And so I think we need to look at this a little more before we jump to conclusions and just say it's a negative study. If it had been truly negative right across the board, we would have been asking why that's so. So I think that even if you don't get improved response or improved overall survival, patients may prefer a period on immunotherapy just because they don't get the side effects. Whether the regulatory bodies and the people that pay for the stuff will subscribe to that, I don't know. And we've still got a lot of sorting out to do in this area. I think Keynote 45 is very important in that it very much presents a benchmark for us to go forward, where we say, okay, we can do better than what we were doing in this area with these new drugs. And then for the other 4 agents, and I think there might be another 3 on top of that, in the next year, we've got some big questions to ask about whether they produce differential value, whether they can be dosed differently and more efficiently for similar outcomes. So we're in a good place, but some of the data is a little bit confusing. Most of the data coming out of Keynote 45, I think, are very straightforward. When we originally designed the study, there was a thought that PFS might be important, and in fact, if you look at the design of the study, it had co-primary endpoints of progression-free survival and overall survival, but with the preference for overall survival.
Right. Can I finish up with 2 clinical scenarios to ask you then? So a patient in Australia currently can't access immunotherapy for bladder cancer without self-funding. So I have a 79-year-old woman who presented ECOG2, maybe even ECOG3, quite unwell with liver metastases. She couldn't take cisplatin-based chemotherapy, but with some steroids, ECOG2, very keen for chemotherapy, had 2 cycles of carboplatin and gemcitabine with a very brief response. But then it's progressing, and the family come to me and say, we'd like to self-fund immunotherapy. She now spends most of the time on a couch or in bed, and she's wheeled in a wheelchair to see me. Her albumin's 20 and she's got liver metastasis. How would you have a discussion about, the benefit of immunotherapy, given that her family would have to pay, $6,000 every 3 weeks for Pembrolizumab?
So I think that a patient with an ECOG status of 3, a low albumin and declining performance status is very unlikely to benefit from immunotherapy. It takes a while for this stuff to actually work and get the patient better, and I think they have to have an immune system that will help them respond. And what I'd say to them is that I can't work out how they should spend their money. It's something that I can't calculate as an oncologist, and I think most of us can't do that. But the problem here is that if we look at the subgroup analyses of several of the immunotherapy studies that have been done in, say, melanoma and lung, and they'll come in urothelial cancer, the older patients do not seem to have benefited that much from immunotherapy. So I'd be more inclined to say, okay, in all honesty, if this is my mother or my grandmother, I think that I would be trying to do the best palliative care I could, rather than expending the family fortune, mortgaging the house to pay for 12 weeks of immunotherapy. And I think also if that patient qualifies and they can get coverage from their insurance, you may have to ask the same question. Just because the PBS or Medicare or whatever is paying for it doesn't mean that we should be any less prudent with things. And I think for this patient, I would be trying to get her the best palliative care I can, and I certainly wouldn't give her any more chemotherapy either.
Great. So just one more question then at the end of the clinical spectrum. A patient of mine in his 70s, quite fit, sails his boat, goes skiing, quite a wealthy retiree. He developed a metastatic urothelial malignancy arising from his ureters, bulky retroperitoneal lymphadenopathy, didn't want chemotherapy, wanted to self-fund Pembrolizumab, and embarked on treatment. He's had now 9 months of therapy with fantastic improvement in his quality of life, with a radiological tumour shrinkage. It certainly doesn't meet the criteria for tumour response, but his tumour measurements hasn't changed now for the last 6 months on therapy, and he's up to about 12 months on treatment, and he's paying $6,000 every 3 weeks. What do you think about the duration of therapy in treating patients? I'm not talking about a complete responder. I'm talking about someone who's still got measurable disease.
So we don't actually know, and we don't even know for complete responders. But what we've taken to doing is that where we think the patient's benefited, and this guy's benefited, we will offer them to stop therapy at 12 months. Why 12 months? It's a number. And based on the melanoma and some early lung data, if patients then progress, they'll usually respond again. Now, they're responders. They've had a 50% volume fall or a complete response. And so it's an area that's evolving. But I would be inclined to say to the patient, look, we're treating her every 3 weeks. We can take a break and do a scan in about 12 weeks, and I think we're reasonably safe. If you develop symptoms, we'll have to do it earlier, but there may be things you want to do. And many of the patients go a while after we stop them, even if they're setting of what we'd call a minor response. And we're just starting to see our patients recurring now after maybe a 6-month break at earliest, and we're putting them back on, but I don't have any even anecdotal information about restarting them. Their performance status seems to remain pretty good. And so I think we need to work out whether we can break therapy at that point. It'd be lovely to have some clinical trials or even a repository to collect the data on these patients.
Yeah, I think it's an area that needs collaborative research with investigators, since the drug companies that so far haven't proved very interested in early discontinuation trials. I think SWOG and other alliance trials groups are set up to try and meet those sort of answer those questions.
I think what you need to remember is that you're looking at multiple different constituencies for the drug companies. So if they have a situation where we decide to stop patients in Australia at a year and and retreat them. Whoever's funding that drug in Australia, whether it be the PBS or whatever, how will they interpret that? The need to restart after what could be 6, 9, 24 months, and whether they should pay for it again, because most often they would consider people to be resistant. And so, just how things are interpreted in different settings can be kind of difficult. It is something we need to take on as cooperative groups, and I think it's something that the public purse should be expending for with the help of the companies, and hopefully we'll get to that point. We have several studies planned in SWOG to look at this, and we're looking for partners, and hopefully we can do it with ANZUP and some other people as well.
Well, that'd be fantastic. Well, thanks a lot, David, for your talk and insight into immunotherapy and bladder cancer. It's been a pleasure.
Thank you very much.
Thank you.
Thank you.